Good morning. Nice to be here. I would like to thank Mr. Adonagianakis, Maria Pedramani, and the organizing committee for the honor to participate in the work of one of the most successful conferences on shoulder diseases. One of the shoulder diseases that often were called to rehabilitate is frozen shoulder. One condition that can be extremely disruptive to life. In my presentation, I would like to show how fascia, a new tissue in our approaches, how fascia evolved with frozen shoulder, and the importance of including fascia manipulation in our treatment. All these years that I have been working on the restoration of frozen shoulder, I had many questions, such as why does a frozen shoulder appear in people who have no trauma, injury? Why do patients experience pain in remote areas like elbow, wrist, spine, chest? Why does it occur in some patients after shoulder surgery? Not for a frozen shoulder, for other surgery. Why after surgical repair of frozen shoulder, while the movement have been restored, the patient have still pain? And does the autonomic nervous system play any role to all this? Some of these questions were answered when I started studying about fascia. When dealing with musculoskeletal disorders like frozen shoulder, therapists are continually faced with the dilemma on where to focus, where to apply pressure or friction. This becomes the key question because the shoulder, as any other joint, is part of interrelated system, and its relationship with the rest of the body is an essential part of its functionality. One manual technique that provides an effective treatment to specific areas of muscular fascia is fascia manipulation. Fascia, what a fascinating tissue. Looks like that. This here is hyaluronic acid. Researchers do not agree on one general definition of fascia. However, it is undeniable that it forms a three-dimensional structure with many interdependent layers located at different depths from the level of the skin to the periosteum. Also known as a dense irregular connective tissue, this tissue surrounds and connects every muscle, even the tiniest myofibril, and every single organs of our body. It forms a tube continuity throughout the whole body. Fascia has been shown to be an important element in our posture and movement organization. Fascia is a tissue of our body that has evolved a number of processes, including pathological ones. This happened because it is a metabolically active, vascularized, and innervated structure, containing both myelinated and non-myelinated nerves, fibers, and Schwann cells. The deep layer of the muscular fascia and the tendons are richly supplied with small diameter afferent nerve fibers that can conduct pain stimuli. This is very important. And autonomical nerve fibers have also been shown to be present in the deep fascia. Fascia, nevertheless, is densely innervated by mechanoreceptors. which are responsive to manual pressure. Stimulation of this sensory receptor have been shown to lead to a lowering of sympathetic tone as well as change in a local tissue viscosity. This is very important for the gliding of fascia. The presence of many free and encapsulated nerve endings, particularly Ruffini and Pacini, indicates that the deep muscular fascia probably plays a proprioceptive role. This is very important and for manual techniques and for Pilates. The capacity of various collagen layers to slide over each other can be altered in cases of overuse syndromes, trauma, or surgery. In such cases, the amortizing mechanism of the fascia or the nerve endings is lost, causing a correct paradoxical activation of nerve receptors within the fascia, resulting in the propagation of non-receptive signals, even in situations on normal physiological stretch. So if the fascia is not gliding, the signals that goes in the central nervous system, it's not physiological, even in a normal movement. Pauletti and Stecco hypothesized that the deep fascia between two joints carradines perceptive and directional continuity along a specific myokinetic chain. Maybe this is why they have pain in other areas, acting as a transmission belt between two adjustment joints and also between the synergic muscle group. Here we can see the continuity and how the muscles go together with each other. Here we can see the connection between capsula and tendons in the shoulder joint. The tendons attach the capsule, so any force transmits to the capsule. So, all the bones, ligaments, muscles, tendons, arteries, veins, nerves of the body are covered by fascia. This fascia not only blankens these structures, it also contains blood vessels and nerves, as we saw before. These nerves are able to sense both pain and strain and will transmit this information to the spinal cord, where they connect to motor neurons which affect the muscles and to neurons of anatomic nervous system which affect blood flow. In response to injury, tissue irritation, or inflammation, or perceived threat, this connection of the nerve will create a protective muscle spasm and also limit blood flow, which then leads to limited range of motion due to pain as well as swelling in affected area. The fascia directly overlying the affected structure will be tightened well, not only the muscle, also the cover of the muscle, fascia. When this protective mechanism has been triggered, it will limit joint mobility, increase tension within the joint capsule, and cause pain when the joint is moved into the restricted range. Even ligaments that support the spine will refer tightness into the joint of extremities when they are in stage of protective spasm. So, a successful outcomes requires treatment to all the involved structures, not just the 2 or 3 obvious ones near the shoulder. Based on the recent anatomical and histological studies, fascial dysfunction is one of the causes of frozen shoulder. According to that, accumulation of fibroblasts or contractile myofibroblasts and periatricular facial layers have been reported during the past or present inflammation processes around the frozen shoulder. About fascia manipulation. The fascia manipulation helps to improve fibroblast proliferation, normal collagen alignments, and normal gliding on fascia layers. The fascia is allowed to relax, improve, soften, and can be lengthening throughout enhanced synovial lubrication. The fascia is manipulated with direct or indirect methods like Pilates, allowing the components of the fascial layers to reorganize themselves into a more flexible functional fashion. It is one of the essential techniques in the dysfunction or malalignments of the deep fascia. One of the manual methods that do fascial manipulation is Stecco method. Stecco method I'm studying. The Stecco method is a technique which involves deep manual friction over specific points on the deep muscular fascia that are always at distance from the actual site of the pain. In this way, the method can be applied safely during the acute phase or even after surgery. Hyperemia caused by the deep friction could modify the extracellular matrix and restore gliding, change the viscosity of hyaluronic acid. The method is characterized by an analytical procedure that results in personalized treatment of each patient. We have to take a very good history and we have to palpate. So we can see which of this spot and in which line the point is the most acute to treat. I don't know about you, but for me, it was a very big question. Why all the patients with frozen shoulder or tendinitis or any inflammation of the shoulder, they have here in the deltoid, a very painful and very hard point. And when I started to study fascia, I found out this point here, there is connection of different line of fascia. Is genicular traction, there is anterior faction, there is posterior fascia also. So when we release this point, we release in the three directional movement in our shoulder. So in our cases, I couldn't feel, I palpate here, but we have hypothesized the treatment. So if we want to restore flexion, one point could be here in the anterior part of the shoulder. We have to palpate and we have to see if it's product pain or numbness, and then we apply friction. For extension, the point could be here, posterior part of shoulder. Of course, we palpate and we can feel if the point there, fascia, is more thicker. It's different from trigger points. This point is not in the same spot with trigger points. Trigger points refer, they have a referral pain, but it's the points that for manual In fascia, it's different. That lady from the history told us that she couldn't do planks exercises. For that movement, when our patient says that they have this problem or they have pain, and spiral sequence could be involved. And here we can see that spiral inside the hand. So the point could be near elbow or in the hand. And when we release this, we release the fascia in upper part of extremity. So some videos. This is Orpheus with frozen shoulder. His flexion was up there. And here I want to show you, where is my, oh, here I am. Here was one point that even we can see that it's very tight and it was stiff. So I treated with friction. Friction could be with finger or with elbow. Of course, it's painful, but it's very weak. And another part of his posterior part of the scapula. And is in the sequence of movement, and then the flexion is much better. And here I show the point that is shows to be more inflammation or more jelly, but is not so hard. It's more jelly because with this friction we try to change the tight fascia from gel to more fluid situation. Here the method in upper part of trapezium. In sequent line, you can see that I have put spots where the line, where the point is. And I work in the anterior part of the body, chest, yes. Here first feel pain. It's very, very weak. And the results we see after 2 or 3 days. After 2-3 days without understanding how, the patient says that, oh, my hand moves better. Not right, but after 2-3 days, when the fascia start to move better, we have the best results. And if after that treatment they continue to have exercise, Pilates or other exercises, it's good because they will have stimulate the mechanoceptors, and the patient know how to do the movement better. The fascia, because fascia has memory. This is another painful point. If there are physiotherapists here that they do acupuncture, maybe they find out that this point is a very nice point for acupuncture also. There's must be a connection between the acupuncture point and fascia points. So I go down and up, and then, and the posterior part is down. It's between two head of tricep, and then go down. This is a very good point because it's in a sequence of retro movement. Of course, in Steko, there is a very many lines, not only sagittal pain, but in a spiral. This is very important. So this was the internal rotation for Orpheus. You saw how it changed. And then internal rotation is still painful and restricted, but is much better. And for that, I'm going to work on subscapularis. There is a point there, and in a retromedial line. And again, after that treatment, the flexion, internal rotation is much better. Thank you very much.